All right, now let's look at pediatrics now. Now, y'all, let me make something clear. Everything that we've already talked about in med-surg is applicable in the pediatric section. Don't get me wrong. I know your teachers told you that children should not be treated as little adults, okay? But my point is this. On NCLEX, if you get a question about diabetes, which we studied in med-surg, and your patient is 4 years old, you are not supposed to be experts in pediatric diabetes, just in diabetes. Now, what I've tried to do here in this section is pull out the content that is very specific for the pediatric patient, okay? So let's start with nutrition assessment. And the first thing on your handout says general growth within 5 to 95% for height, weight, and head circumference is desired, okay? 5 to 95%. Let's make something clear. The 50th percentile is the median growth. The 50th percentile is the median growth. In other words, the midpoint. And as you would know, 5% is going to be the lowest of growth measurements, the lowest of growth measurements. And of course, 95% would be the highest of growth measurements. All right, so that kind of gives you an idea as far as growth charts and that sort of thing are concerned. All right, now, laboratory tests for assessing nutritional status. Well, hemoglobin, hematocrit, albumin, we all know to check the albumin. Also creatinine, and then nitrogen also. These are all important pieces of lab work as far as looking at the nutritional status of a child. Now, physical assessment for nutritional status includes things like the hair. You know, you always want a child's hair to be real shiny and soft to the touch, that sort of thing. Well, a child that's poorly nourished, their hair is going to be dry and brittle. It may be really coarse and break easily, and it's not going to shine. All right, so that's a nutrition thing. We also look at fingernails, okay? Fingernails, you know, fingernails can tell you a lot. One, about hygiene, okay? Also, it can tell about the emotional status of a child if they're biting their fingernails a lot, okay? Other things we can look at, skin. Well, if you've got a child who's real pale, that could be a sign of anemia. Look at the eyes, especially in babies. Are their eyes sunken? That could be a sign of dehydration. Also, look at the mouth. Of course, you're going to look at the mucosa to look at the color. If it's not moist, are they dehydrated? That sort of thing. Check out their teeth, too. How are they, what's their hygiene like? How are they caring for their teeth? And always check out the gums. You know, anytime you have gums that are bleeding a lot, that could be a sign of poor hygiene or nutrition. And then there's other real complicated tests they can do on the bone and as far as the neurological system is concerned, as far as nutrition. Now, we're not going to get into that. So the basic things you're going to be looking at are the hair and nails, okay? The mucosa, skin, eyes. And when I say mucosa, I'm talking about the inside of the mouth. All right, moving on. How many cups of milk should a 14-month-old consume daily? Average is 2 to 3 cups. 2 to 3 cups. Now, the only reason I even mention that is this. There are a lot of children out there that love to drink milk, and they'll drink 1 and 2 quarts a day if you let them, which can be dangerous because if they're getting that much milk, they're going to be deficit in other areas. We want a balanced diet. Some children really love to drink milk. A school-age child requires how many calories per day? Average is 1,600. That's just an approximate number. And remember, that number's always based on their weight. Now let's look at pain assessment. What pain assessment tool is commonly used for infants 2 months to 7 months of age? Okay, it's the capital FLACC, where they're looking at the face, legs, activity, crying, consolability. Let me say that again. Face, legs, activity, crying, and consolability. Consolability. Face, legs, activity, crying, and consolability. And each one of those is 2 points. Each one is worth 2 points. Okay. Now, 0 is no pain on this scale. 0 is no pain. And then 10 is the worst pain. So it's a 0 to 10 scale. All right, now the next assessment tool is the Wong-Baker Pain Rating Scale, and this is used on children at what age? 3 years and older. 3 years and older. All right, and this is the one where that you're familiar with the little faces, okay? And where they have it's a scale of 0 to 5 usually. 0 being no pain, 5 being the most pain, okay? And the 0 is just a little smiley face, okay? And then whereas 5 is one with tears and the mouth is turned completely upside down, frowning, okay? And the numerical scale for children is used at what age? 5 years and older. 5 years and older. Like, when you're basing your pain on a scale of 1 to 10, that's what we're talking about there. The scale is 0, which is no pain, to 10, worst pain. All right. Now let's get into the review of systems now. Review of systems. Respiratory is the first system we're going to look at. Now, what are observable signs for respiratory dysfunction in children? Well, accessory muscle use. Accessory muscle use. Flaring nares. Flaring nares. Circumoral pallor. Pallor. Sternal retractions. Sternal retractions, pallor, and capillary refill greater than 3 seconds. Greater than 3 seconds. Now, what is respiratory syncytial virus, also known as RSV? Well, it is an acute viral infection which affects the bronchioles. It's an acute viral infection which affects the bronchioles. It affects children 2 months to 2 years. And how is RSV manifested? Well, it begins with a simple URI, upper respiratory infection. URI. Nasal discharge. Mild fever, dyspnea, non-productive paroxysmal cough. Tachypnea with flaring nares. Retractions and possible wheezing. So it starts out with something like just a simple upper respiratory infection, but it progressively gets worse. Now, how is asthma different than RSV? Well, asthma is inflammation of the airways resulting in obstruction. Resulting in obstruction. Signs and symptoms of asthma: cough, shortness of breath, audible wheezing, prolonged expiratory wheezing, restlessness and cyanosis. And what is the most important lesson in proactive care for asthma patients? Well, it's the next statement. Asthma education, specifically identifying triggers that precipitate episodes such as pets, food, environmental conditions, or emotions. Now, speaking of pets, what would be an appropriate pet for a child with asthma? A fish. A fish. Now, also, y'all, since asthma is definitely an airway issue, and it can result in death, I've really elaborated on this in your handout. So I've set aside a specific handout for asthma in this section, okay? So be sure and read that handout. I just went into more detail because it is an airway issue and it is one of the major causes of hospitalizations and visits to the emergency room in children. So it's very important. All right, for several reasons. Now let's move on with the handout. Besides the respiratory complications of cystic fibrosis, what other system is affected? The GI system. The GI system, and you'll see why in just a second. What type of enzymes can be given to help improve digestion? Pancreatic enzymes. When you have a child with cystic fibrosis, they have to sprinkle the enzymes on their food and on their snacks every time they eat, okay? And you never want the enzymes to touch the lips or it can burn the lips. All right? Now then, describe the stools of a patient with cystic fibrosis. Steatorrhea. Steatorrhea. One word says it all. That means fatty and frothy. Steatorrhea. I'll spell it for you. Steatorrhea. Steatorrhea. That means fatty and frothy. And what is the diagnostic test for cystic fibrosis? The sweat chloride test. The sweat chloride test. But how is cystic fibrosis usually discovered? Somebody's kissing the baby and the baby tastes very salty. Somebody's kissing the baby and the baby tastes salty. You see, that baby's losing sodium on their skin, right? Yes, they're losing sodium. Therefore, the child is at risk for what electrolyte imbalance? Hyponatremia. Hyponatremia. So now you have to know about hyponatremia when you're dealing with somebody with cystic fibrosis. In the newborn, what is the earliest sign? They never pass the meconium. They never pass the meconium. You'll see why in just a second. We call that a meconium ileus. Here's why they can't pass the meconium. What are the mucus secretions like with cystic fibrosis? Thick and sticky. Thick and sticky. That's why they can't pass the meconium. Now, is cystic fibrosis inherited? Yes. But you must get the gene from each parent. You must get the gene from each parent. Now let's just talk about cystic fibrosis for a second. When we think of cystic fibrosis, the first thing you need to think about would be thick, sticky secretions everywhere. And the first place we think of those secretions as being is in the lungs. So we have a child that's going to need intensive pulmonary therapy every single day to help them mobilize those secretions, right? But also the GI tract, it's got thick, sticky secretions as well, okay? So that's why they have trouble with digestion, and those pancreatic enzymes can't make it to the intestine like they should. So they can wind up with pancreatitis and all kinds of GI tract problems. Okay? Now moving on. What types of infections are Down syndrome children prone to developing? Respiratory. Respiratory simply because they have a poor immune system. Poor immune system. And what is the most common type of defect associated with Down syndrome? Heart defects. Heart defects. The primary aim in genetic counseling is to inform the parents of their risk, is the magic word. Risk. When somebody comes into a clinic situation and they're talking to you about maybe they're 38 years old and they want to have another baby or their first baby, but they're concerned about congenital defects or Down syndrome, that sort of thing. You always just provide information at that point in time. You give them a brochure that's got their age on it and what their risk factor is at that age. Okay? Now, let's look into the GI system. What is the difference between gastroesophageal reflux and gastroesophageal reflux disease? Well, gastroesophageal reflux is passage of the gastric contents into the esophagus. Whereas GERD is the chronic form of GER, all right? But you have tissue damage here to respiratory structures, which can lead to pneumonia and bronchospasm. So it's worse, isn't it? Now, as far as positioning is concerned, positioning is one of those things that's very controversial. One position they say to use is upright position with feedings, positions with feedings and at night. All right? Another position is the elevated prone position. Elevated prone position. They say that the prone decreases reflux and also improves the stomach emptying. And anytime you're improving stomach emptying, you're decreasing the chance of aspiration then. Okay? All right. Now then, let's look at Hirschsprung's. Well, what is Hirschsprung's disease? Hirschsprung's disease is a congenital anomaly, also known as aganglionic megacolon, that results in a mechanical obstruction along the bowel. Mechanical obstruction. Now, what part of the bowel does Hirschsprung's disease usually affect? The sigmoid colon. Sigmoid colon. And what are the presenting symptoms of Hirschsprung's? Well, constipation, for one thing. Think about that. What happens with Hirschsprung's disease is there is a piece of the intestine that doesn't have any nerves. Well, that's why it got the name aganglionic. That means no nerves. Well, when food and fluid is going through the intestines fine until it gets to that point that doesn't have any nerves. And then everything just stops there, and you have an accumulation of bowel contents in that area. Remember, no nerves, no peristalsis, right there. No nerves, no peristalsis, right there in that spot. So that's why they have constipation. It's an obstruction there. Abdominal distension. And the child could have, especially if it's picked up on in the older child, ribbon-like stools. Ribbon-like stools. All right. Now then, pyloric stenosis results in projectile vomiting, usually after feeding. Usually, right, they'll eat and then they vomit and then they're ready to eat again. This baby's hungry. See, that's kind of different because normally when babies are sick to their stomach, they don't want their bottle. This baby's hungry. They want to eat. All right. Now, gastroesophageal reflux results in spitting up formula with gastric juice. Okay, so they're having reflux with this too. Now, abdominal assessment of pyloric stenosis reveals an olive-shaped mass in the epigastrium region near the umbilicus. That's the enlarged pylorus. That's the enlarged pylorus. Now, let's think about this for a second before we move on. When you have pyloric stenosis, the pylorus is enlarged. That's why you can palpate it, all right? And it's so big that it made the opening in the center of that sphincter teeny tiny. So now the stomach's working hard, trying to push fluid through that tiny little opening, Well, pressure's going to build up in the stomach, and that's why they have abdominal distension. But also pressure builds up, and that's also why when they vomit, it is projectile vomiting, because there's pressure behind the vomitus, okay? And once you ever seen projectile vomiting, you'll never forget it. Now, what would be some important nursing interventions for an infant with pyloric stenosis? Well, hydration, of course, because they've been vomiting a lot. Intake and output, daily weights, urine-specific gravity, okay? Urine-specific gravity. One of the things that they do with pyloric stenosis is surgery. They just go in and open up the center of the sphincter so fluid can get through more easily. Now, what would be a top nursing diagnosis for a client with cleft palate or cleft lip, or maybe both? Alteration in nutrition. Alteration in nutrition. That's why they have to be fed with an elongated nipple down the side of the mouth, or with a medicine dropper down the side of the mouth. Anytime you're feeding a baby medicine, and here it's a feeding, you put it in the cheek, in the side of the mouth, because if you put it in the center, they're going to choke and aspirate. Now, when a baby is born with a cleft lip and palate, which problem do they correct first? The lip. You would think they would repair the palate first, but they actually wait on the palate. Why? Because when you're born, your palate is mainly made of cartilage. Cartilage doesn't do well surgically, okay? So they're going to wait till there's more bone formation in the palate. They hurry up and repair the lip to promote bonding. They repair the lip to promote bonding. Now, why should an infant with a cleft lip and palate be bubbled, that just means burped, frequently? Because they swallow lots of air. They swallow lots of air, more so than normal. And anytime you've got a baby that's swallowing lots of air, that puts them at risk for abdominal distension, which puts them at risk for vomiting and then aspiration. That's what I'm scared of, is aspiration. The nurse should position a child on the back or side line position following cleft lip repair. The goal is to protect the suture line and do not place in the prone position. They're going to mess up their suture line. Now, what will the suture line be cleaned with post-op? Saline. Saline. And when is the best time for cleft palate repair to be done? Before speech develops. That's usually between the ages of 1 and 2. Before speech develops, between 1 and 2. And I almost skipped one. With cleft palate repair, why do we avoid putting things in the child's mouth? I'm talking about hard things in particular, like straws and thermometers and cookies. Because we don't want to disrupt the suture line. We don't want to disrupt the suture line. They have to be on a soft diet. They have to be on a soft diet until it is well healed. Now, are speech defects common after a cleft palate repair? Yes. Don't you agree that your palate is very important for helping you articulate words? Yes. Now, what restraint would the nurse select following cleft lip repair? If you had to pick a restraint, now I know we stay away from restraints as much as we can, but if you had to pick a restraint, you would pick elbow restraints. Elbow restraints, because that's going to keep their arms straight. Keeps the arms straight so they can't get their hands into their mouth. And we always follow hospital policy concerning restraint use. All right, next thing we have, what are the clinical manifestations of intussusception? A different problem now. Well, first of all, it's a sudden onset, cramping, abdominal pain, inconsolability, and drawing up of knees. Now, here's the deal. You've got a child who's playing, having fun, everything's okay, and then all of a sudden they scream out in pain and they draw their legs up to their chest and they hurt, and then it's over with. So they're really having episodes of pain. Now, what is an intussuscepted bowel? This is when a piece of the bowel goes backwards inside of itself, forming an obstruction. Goes backwards inside of itself, forming an obstruction. Now, a classic symptom of intussusception is current jelly stool. Current jelly. That just means it's maroon colored. It's got blood in it. It's got mucus in it. Now, what should you be monitoring closely in a child with intussusception? Their stools, of course. Because think about it. If they've been having current jelly, and then all of a sudden they have a normal stool, what does that mean? That it fixed itself. It fixed itself. The doctor wants to know that. If it fixed itself, hey, they may be scheduled for surgery or something like that. And even after surgery, to repair this, sometimes they don't have to do surgery. Sometimes they can just use a barium enema, and they think the pressure of the barium going in will push out the telescoped area. Others have to have surgery. But even after barium enema or surgery, they keep them in the hospital for 3 days. Why? Because it might just come back. It might just reoccur. And so we're going to watch them for a while. Celiac spruce is a genetic malabsorption disorder in where there is a permanent intestinal intolerance to gluten. In other words, they're allergic to it. An intolerance to gluten. There's a hypersensitivity and allergy there. Now, important teaching with celiac disease. Lifelong disorder. They're not going to get over it. No food with gluten. Vegetable proteins. They cannot have brow. What do these letters stand for? Barley, rye, R-Y-E, oats and wheat. Barley, rye, oats, wheat. Now, what can they have? RCs is the way I remember it. Now, what do these letters stand for? Rice, corn, soy. Rice, corn, soy. All right. In esophageal atresia, why can't the saliva make it to the stomach? Because the esophagus ends in a blind pouch. The esophagus ends in a blind pouch. All that means is the esophagus is closed off at the bottom, and it's not connecting to the stomach like it should. Why do babies with esophageal atresia not have meconium? Because they never swallowed any amniotic fluid. They never swallowed any amniotic fluid. Now, how are babies with tracheoesophageal fistula or esophageal atresia usually fed? With a gastrostomy tube. A gastrostomy tube straight into the stomach. Now, when studying tracheoesophageal fistula, what are the 3 C's? Now, what I'm talking about is this, y'all. First of all, what is a fistula? An opening. And if you've got a tracheoesophageal fistula, you have an opening between your trachea and esophagus. So if you have an opening between your trachea and esophagus and you drink a Pepsi, what are you going to do? Coughing, choking, cyanosis. Coughing, choking, cyanosis, especially with drinking. Especially with drinking. That's why your teacher told you to watch the first feeding so closely. To watch the first feeding closely, because if they start coughing and it bubbles out their nose, they could have this disorder. That's also why your teacher told you that the first feeding needed to be something sterile. Something sterile, like sterile water or breast milk, either one, sterile water or breast milk. Because if they do aspirate, you want them to aspirate something sterile, don't you? With tracheoesophageal fistula, the type where there is a connection between the esophagus and trachea, what would the top nursing diagnosis be? Potential for aspiration. Potential for aspiration. Before corrective surgery of a tracheoesophageal fistula, the infant is placed on its back with head and shoulders elevated. Why? Because we want the secretions to pool in the lower esophagus. We want the secretions to pool in the lower esophagus. You would rather the secretions be there than over into the lungs, you see. Now, why is it not uncommon for a mother to have hydramnios, sometimes called polyhydramnios, with infants with GI tract problems? Because the baby never swallowed any amniotic fluid, once again. And so it just builds up and builds up and builds up. So when you've got the pregnant person going to the doctor, one of the things that they look at with the ultrasound is the amount of amniotic fluid the patient has. Now, with imperforate anus, there is no rectal opening. Therefore, the baby will not pass the meconium. Well, obviously, if you have a baby that's born without a rectal opening, they're going to have to create one, aren't they? Yes. So this is a baby that's going to have surgery. And many, many times when you have someone who's had surgery anywhere on the GI tract, they might come back with a temporary colostomy, just like we talked about in the med-surg section. Okay? Temporary colostomy. Now, the purpose of any temporary colostomy is to allow the intestines time to rest and heal. To allow the intestines time to rest and heal. Now we have hematology. The first thing we're going to talk about here, sickle cell. Sickle cell disease is a hereditary disorder in which the hemoglobin is partly or completely replaced by sickle-shaped hemoglobin. Therefore, we have a reduced oxygen carrying capability now. Clinical manifestations of sickle cell disease are pain in the area of involvement. You see, you have all these little sickle-shaped cells floating around in the blood. That sickle-shaped, C-shaped cell can get tangled up, all right, which forms little clots all over the body, which can be painful. Anorexia, exercise intolerance. Well, you're talking about somebody who's anemic here. So no wonder they have exercise intolerance. Now, if you have somebody in a sickle cell crisis, the things to remember are bed rest. Put a big star by hydration. That's the number one thing that will stop the sickling process. Hydration. Analgesics, antibiotics, possibly blood transfusions, and oxygen. But hydration is the most important thing because we've got to stop the sickling process. Now, leukemia is the most common form of childhood cancer. The definition of leukemia is cancer of the blood-forming tissue, and it's proliferation of immature white cells. Now, do immature white cells do you a lot of good? No, so you've got somebody that's immunosuppressed. And there can be so many white cells, y'all, that there's no room for platelets. So now we also have somebody that's thrombocytopenic, so you can't forget that. But now there's also no room for red cells. So now we also have somebody who's anemic as well. So always think of those three things: immunosuppression, thrombocytopenia, and anemia when you're thinking of leukemia. Now, there's two types of leukemia here. ALL stands for acute lymphoid leukemia. Lymphoid. And AML is acute myelogenous leukemia. Myelogenous. 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 Clinical manifestations of leukemia are fever, pallor, anorexia, petechiae, vague abdominal pain, easily acquired infections. And most of those signs and symptoms go back to anemia, immunosuppression, and thrombocytopenia. Now, Wilms tumor or nephroblastoma are found where? In the kidney or as an abdominal mass. In the kidney or as an abdominal mass. And the most common presenting sign is swelling or non-tender mass on one side of the abdomen. And some very important things to remember with Wilms tumor are: don't palpate the abdomen, everybody knows that, and gentle care with bathing or moving the patient. Now, let's go on to neuro now. Hydrocephalus is a disturbance of the ventricular circulation of the cerebrospinal fluid in the brain. So we're having a buildup of CSF, right? Increased intracranial pressure is what we think of here. Now, clinical manifestations of hydrocephalus are palpation of the anterior fontanelle, dilated scalp veins, depressed eyes. See, normally the forehead is protruding in this baby, so the eyes will appear sunken. Irritability and changes in the LOC. Also, I bet your teacher said in school, high-pitched cry. Yes, a very high-pitched cry. Now, we always study the high-pitched cry with hydrocephalus, but any baby with ICP or meningeal irritation can have that high-pitched cry. Now, surgical treatment for hydrocephalus consists of the insertion of a VP, ventriculoperitoneal shunt. Ventriculoperitoneal shunt to drain out that excess fluid, okay? Now, remember, it's not that much fluid, but a little extra fluid up here can make your ICP go up, okay? Post-op care of a VP shunt includes frontal occipital circumference, measuring the frontal occipital circumference, fontanelle and cranial suture line assessment, monitor the temperature, supine position, and hydrocephalus is frequently associated with myelomeningocele. In other words, the sac on the back. The sac on the back that can be filled with spinal fluid, spinal nerves, and maybe even part of the spinal cord. Okay? Now, when somebody's born with spina bifida, I know your teachers told you to protect that sac. Do not let it rupture, right? So now we do have a baby who's lying prone flat, okay? While we're waiting to have this repaired back here. Okay? And sometimes doctors want you to put a sterile dressing, moistened sterile dressing over the sac so it won't dry out. So we're hurrying up and getting that baby to surgery. Musculoskeletal now. Scoliosis is lateral curvature and rotation of the spine. Lateral curvature and rotation of the spine, and this can be genetic. Now, management of scoliosis consists of the 3 O's. What are the 3 O's? Well, the first one is observation, orthosis, and operation. Observation, orthosis, which is spelled O-R-T-H-O-S-I-S, orthosis and operation. Now, the operation usually is spinal fusion with rod, okay?